So welcome everyone today. We are going to move on to session 4. And session 4's title is Lifestyle Management and Behavioral Health Across the Care Continuum. And we have 4 speakers. And I'd like to introduce the first speaker for today, Bernard Fuemmeler, who will talk about diet, physical activity, and weight.
Okay, thank you very much. Like Dr. Fasciano said, I will be talking about diet, physical activity, and weight. And my name is Bernard Fuemmeler. I'm at Duke University, and I'm honored to be here and present. So I need to find, oh, here we go. I want to just preface my talk a little bit by saying that the literature in this area covers 2 bodies of work, and one is adolescent and adult survivors of childhood cancer that were primarily diagnosed as children. And so there's more studies of diet, physical activity, and weight in this type of patient population. And then there are young adult survivors who were primarily diagnosed during young adulthood or late adolescence. And there are fewer studies that have looked at diet, physical activity, and weight in this type of patient cohort. Good nutrition and regular physical activity offer many benefits to cancer survivors, and this is recognized because it promotes healing of tissue and organ damage, promotes healing of tissues and organs damaged by the treatment. It helps build strength and endurance, and it reduces the risk of adult cancers and other chronic diseases that may co-occur with survivorship. And also, it's been shown to decrease stress, so that's an important part of wellness and healthy living as well. The effects of cancer on weight have been most prominently evaluated with respect to ALL, and the risk for obesity is well documented in patients with ALL, childhood cancer survivors. And there's been some seminal epidemiologic studies that have come from the childhood cancer cohort which show that obesity prevalence among survivors is greater than the prevalence in the population. And there are some variations in terms of what presents a higher risk factor. So having cranial radiation therapy, being diagnosed at a younger age, and female, those characteristics have higher prevalence of obesity in that cohort. And you heard Dr. Tai's talk yesterday about the BRFSS data, and that study just came out where they showed it wasn't specific to a diagnosis, but they showed that being an adolescent survivor of cancer increased the risk of obesity, and the prevalence of obesity was higher in that patient population compared to the population norms. So some evidence that it's not just ALL that we need to be concerned about. What some of these larger cohort studies tell us is important about the prevalence of obesity in certain patient populations, but there's more work that needs to be done about what does weight gain look like over the course of treatment. And let's see. So I'm highlighting this study because I think it's an interesting study. What they did is they took height and weight data from medical records and looked back at weight gain over the course of the first year, or actually over the course of treatment for high-risk ALL that were treated on a particular COG protocol from 1996 to 2002. And they essentially showed that 23% of the patients were obese at the end of treatment compared to 14% at the beginning, that obesity was highest among those 5 to 9 years of age, among the non-white cohort, and among those who initially had a higher BMI, but radiation was not a factor in their sample. The greatest increase in weight occurred between 9 to 12 months post-diagnosis, and so this was right at the maintenance phase of the treatment. And they basically ended their article by saying this may be a good time to think about diet, physical activity, weight interventions when weight gain is starting to increase, and we want to make sure that it's increasing in a healthy way instead of presenting a risk factor for them later on. The BMI data doesn't tell us the full picture about what may be going on with respect to body mass changes and adiposity. And this study looked at adult survivors of childhood cancer, and they found that in their cohort, the BMI was not different between the survivorship group and the sibling control group. But when they looked at DEXA scans and they looked at adiposity, there was a difference among males, with males having greater visceral fat and trunk fat, body fat. We looked at this also in a small cohort, a pilot study, where we followed 15 patients who were newly diagnosed with ALL and recruited a community cohort that was matched on age and sex and race. What we found was that there were not statistical significant differences in body fat, but there were a trend towards marked increase in body fat in the cancer group, where that group was putting on more visceral fat, more adipose tissue in the first year compared to children who were growing normally, healthy children. So this is sort of causes some concern that perhaps during that year of treatment, children are not being as active as they usually should be, obviously, and they're losing the opportunity to gain lean muscle mass. I think it's also important to recognize that weight gain is not necessarily a factor just for the patient, and I like this slide, and I wish Ashley was here because this is her work, and I always come back to this slide because I think it's important to recognize that parents too, also, they gain weight during that first year of treatment, or the first 3 months. They compared the weight gain among parents to weight gain in a matched control, and they found that the parents of cancer survivors also gained more weight during a similar amount of time. So there's the stress of the illness that may be contributing to a family dynamic of weight gain, and so that's something to be concerned about as we think about our patient populations. With respect to diet, there's little evidence to suggest that the quality or quantity of food intake of AYA survivors is different than the general population. There is some evidence that during specific times they may differ. So during childhood cancer treatment, a high caloric dense diet might be promoted for children to gain weight. And then glucocorticoid therapy may increase appetite. But overall, with the studies that have looked at this, haven't found much evidence that there's much difference in the survivor group versus the healthy control group. But this is not, we shouldn't raise our wine glasses and cheer about this, because this is still a concern. This patient population is not meeting some of the recommendations. And this has been highlighted in a few studies here, and I chose these studies to look at because there are some of the studies that have used at least some standardized assessments of diet, and they're more recent studies. So in these studies, they've shown that a small percentage are consuming the recommended amount of fat in their diets, so 16 to 54%, depending on which study you're looking at. And the percent that's eating 5 or more fruits and vegetables is also low. And again, this is not different from the general population, but it's still not good given the risk factors that may occur later on for these patient populations. With respect to physical activity, the story is a little bit nuanced. There is some evidence to suggest that AYA survivors have lower levels of physical activity and greater sedentary activity than their healthy peers. And part of this may be the impairments in physical functioning that impact the ability to exercise. Also, as I mentioned, there may be developmental times when they're not acquiring the normal lean mass that they need for playing and growing up healthy. So here are a few of the studies that I've highlighted that, again, I chose them because they were either a large epidemiologic study or because they show they've used at least some method of assessing physical activity in a standardized way. And essentially, across these different studies, we're seeing that, again, that survivors are less likely to meet the guidelines than population-based norms, that they're less active and more sedentary than their sibling counterparts, and many are not meeting the recommended guidelines for physical activity. I think there's some limitations of the current literature. Few studies have used standardized measures of diet and objective measures of physical activity. The performance of these self-report instruments, especially for physical activity, really hasn't been evaluated in this patient population. And while it's been evaluated in larger epidemiologic studies, there may be ways in which patients are misinterpreting the level of physical activity that they're engaging in when they're reading questions about being engaged in activities that make you breathe hard, for example. So I think we need to do a better job of using some objective measures, at least, of physical activity. Self-report of BMI is often used for these types of studies, and that's becoming better as we've sort of moved from larger epidemiologic studies where we can measure this more accurately. But few studies have looked at using direct measures of height and weight or assessed body composition. And we know a little bit about the correlates of physical activity and weight management in the general population, and they're probably similar, but there may be some cancer-specific things that we need to be aware of, like fear of injury and fatigue and pain, or the belief that you can be active after treatment. So those are some of the things that are beginning to come out in the literature, and we need to see more of that. I think it's also important to note that there is a high demand for programs from this survivorship group for weight management. When these two studies have asked patients, what do you want to see these types of programs, and 40, 50, 60% say they'd like to get in shape and exercise more. 50% want to have programs that will teach them about healthy eating. Weight management is not as huge of a concern, although it is among 40% of the patient population. But living a healthy lifestyle is important to the patient population. And unfortunately, there are very few interventions available that we can begin to disseminate to this patient population that have been tailored for survivors. So I think there are some challenges and the reasons why some of these interventions have been slow to develop. And one is, I think, that we're faced with a patient population that's geographically dispersed around a cancer center usually. So they're spread out all over the state, so sometimes it's hard to reach them, to get them to be involved in interventions that we're designing. And we have not done a great job of looking at developmental tailoring, and this was mentioned yesterday about the importance of the developmental stage and developmental age. And so we need to do a better job of considering what stage they are as a survivor developmentally. Programs that have attempted to do something like this, change diet, change physical activity, have generally had very high attrition rates. So participants come for the first couple of group sessions about nutrition or the group exercise sessions, and then they don't come after that. So it's hard to get them involved in programs that target these types of healthy lifestyles. Distance-based delivery channels are typically preferred, and Wendy asked patients in a study on this, and they would rather have mail-based and internet-based types of programs compared to in-person types of sessions. Now, there are some novel approaches that are starting to emerge with respect to this patient population. And this one here by Rabin it was a pilot study. She essentially adapted a internet-based physical activity program for young adult cancer survivors. And she looked at the feasibility of implementing this in that patient population. She did a 12-week trial pilot study. And she showed that participants in the intervention had reported at least more activity than their control group. And there was high acceptability. So the patients that were involved in that seemed to enjoy that type of internet-based physical activity intervention. This study by Valet recently came out, and she used Facebook as a way to implement the intervention. She recruited and also implemented the intervention through Facebook. They called it FitNet, and they recruited adolescent young adult cancer survivors. 45 were in the intervention group, and the intervention was designed so that modules about physical activity could be delivered on Facebook to the intervention group. The self-control group had access to the Facebook page, but they didn't necessarily have those specialized modules around physical activity. They also each had access to an internet-based site for tracking and monitoring physical activity. So both groups actually increased their moderate vigorous physical activity. And so they didn't find any group effect here. But again, this was acceptable to many patients. They like the idea of having this available on Facebook, a site that they use a lot. We've been doing a little bit of pilot work also with adolescent cancer survivors, and what we were interested in is with developing a mobile phone app for teenagers that would engage them in diet and physical activity. So we developed a platform that includes a smartphone app and a decision support tool that we can use, a health coach can use to intervene with the patients. And participants, essentially we wanted to develop it as a game, so because we want it to be fun for adolescent survivors. So participants essentially advance through a series of expeditions to save the world. The Earth has been destroyed, and it's up to a band of survivors to discover the secrets that heal the planet by finding out about the Mila bloom. And so as they engage in tracking their diet and engage in syncing their pedometer with the app, they earn points and badges, and they progress through a series of expeditions. And so here I'm just showing a few of our screenshots here. And so there's a map screen which kind of shows their progress. It shows the badges that they've earned for completing the expeditions, shows their points. And they also receive some weekly challenges to challenge them to do something healthy that week. They can track their fuel, their diet, through the stoplight diet, so learning about what is a red food or unhealthy food, foods that you want to veer away from. And they also track their steps using an external pedometer that can sync with the app wirelessly. And then there's a chat screen where participants can post messages to one another. We can post messages to them. They can exchange information about things that they've done, and also encourage one another. So in summary, this survivorship population, they appear to be at higher risk for overweight and obesity compared to their healthy peers, and there are some factors that increase the risk. They're similar to the general population with regard to their diet, but they still have poor diet by recommendation standards. They're not participating in as much physical activity as their healthy counterparts. And there's high demand for interventions from this patient population, but low supply. Not enough work has been done to provide that. So I think what we need to do moving forward is, as I mentioned, we need to improve the measurement methods, both in epidemiologic studies and intervention studies when we're looking at changing diet and physical activity. We need to better understand the cancer-specific social and psychological factors that relate to unhealthy eating in this population. And we need to think about our interventions as being able to reach a geographically dispersed population if we're going to have some success at translating this. And we also need to think about the developmental stage of our interventions, of the programs that we're developing. We can't expect that something that's going to appeal to the upper 20 or 30-year-old patient population is also going to appeal to the 16-year-old. So we need to be mindful of that and think about what the way in which we want to design those types of approaches. That's the end of my presentation. Thank you.